Good morning and welcome to our breast cancer panel. I'm Dr. Jennifer Croizer from Baptist MD Anderson Cancer Center in Jacksonville, Florida. Today we have an expert panel to present a cancer case to you that we will go through step by step. First, I'd like to introduce Dr. Reshma Mahtani.
Hi everyone, I'm from the Sylvester Cancer Center, University of Miami, and I'm a breast medical oncologist.
And next on our panel is Dr. Kristina Mirabeau Beale.
Hello, so I'm a radiation oncologist in Fort Myers, Florida, with Genesis Care USA, previously known as 21st Century Oncology, and I'm the director of our breast cancer program at our regional cancer center.
Next is Dr. Maria Rueda-Lara.
Hello, everyone. I'm a psychiatrist, psycho-oncologist, and I work at the University of Miami Sylvester Comprehensive Cancer Center.
And next is Ms. Mayra Lima.
Good morning. My name is Mayra Lima. I'm a nurse practitioner in the University of Miami Sylvester Cancer Center, and I work with the breast cancer team.
Perfect. So we'll go ahead and get started with our case. So first, we have a 59-year-old woman who presents with a palpable 2.5 centimeter left breast mass that's biopsy positive for invasive ductal carcinoma, grade 3, ER negative, PR negative. HER2 is positive 3+ by IHC. She has one lymph node that's positive on ultrasound guided biopsy, and all her other axillary lymph nodes appear normal on imaging. She has a history of hypertension and hyperlipidemia, which are well controlled, and also a history of anxiety and obesity. Her family history includes a maternal aunt with ovarian cancer and no family history of breast cancer. Next up, we would like to discuss surgery or neoadjuvant therapy, and we'll turn it over to Dr. Mahtani.
Thanks, Jen. I'd like to just start by making some general comments about the case and just say that I appreciate the opportunity to be on a multidisciplinary panel as we approach this case from all angles. As we know, it takes a team to address all the issues, and this doesn't include just systemic therapy and local therapy decisions, but also the mental health of our patients. And last but certainly not least is the very important support that we get from our nursing and advanced practitioners, who are the ones that really are day-to-day helping us with patient care management. A few, again, general comments about the case. It's notable that the patient is obese and has anxiety, and there's an increasing body of evidence that links anxiety and stress to cancer, as well as data that shows that stress management improves quality of life during and after treatment of breast cancer patients. And I'm sure we'll hear more about this from Maria. She'll go through some of these issues with us. And also the link with obesity, especially after menopause, and breast cancer risk is well established. And in future programs, I'm sure we'll tackle some of these issues with our integrative medicine colleagues. So as far as the systemic therapy decision on this case, it's nice to start with a topic where we have a good deal of consensus, and that's regarding the utility of neoadjuvant therapy in HER2-positive breast cancer. So this slide illustrates who should be considered for preoperative systemic therapy. Again, we generally consider neoadjuvant treatment for patients that have a high tumor volume to breast ratio, where we're trying to achieve breast conservation, lymph node positive disease, high risk features, including high grade, hormone receptor negative. You'll see HER2 positive as it's relevant to this case is highlighted, or triple negative. And of course, with younger patients, it's also a consideration. Specifically, again, back to our case, patients with HER2 positive early breast cancer who have a tumor greater than or equal to 2 centimeters T2, or who have node positive disease should receive neoadjuvant chemo with trastuzumab and pertuzumab. Now, this recommendation is based on pivotal studies that are shown here. These are the pivotal trials that looked at neoadjuvant trastuzumab and pertuzumab for patients with HER2 positive early stage breast cancer. The first is the Phase II NeoSphere study, in which chemo-naive women with early stage HER2 positive disease with primary tumors greater than 2 centimeters were randomized to one of 4 different preoperative regimens that all included an anti-HER2 backbone, followed by surgery, followed by anthracycline-based chemotherapy, with the primary endpoint being PCR in the breast. Also of note, the Trifina trial, a phase 2 cardiac safety trial, looked at patients that had operable, locally advanced or inflammatory breast cancer, again, randomized to one of 3 arms, 2 of which were anthracycline-based, and the third, which was not an anthracycline-based regimen, followed by surgery to assess PCR adjuvant treatment to complete 1 year of trastuzumab. And the primary endpoint in the Trifina trial was actually cardiac safety. In terms of the NeoSphere trial and the results, you'll see in this table the PCR for each of the arms. Again, as we just went through, patients received 4 cycles of randomized neoadjuvant therapy followed by surgery, and 3 cycles of anthracycline-based therapy and trastuzumab. You'll notice in the intent to treat population, arm B, pertuzumab, trastuzumab, and docetaxel had the highest PCR rate, 45.8% as compared to trastuzumab docetaxel. And you'll also notice, and this is interesting, that about 17% of patients were able to achieve a PCR without chemotherapy at all. And that's an interesting observation, which will hopefully inform future trial design to select out who may be spared chemotherapy. And then, of course, as expected, the ER positive patients had a lower PCR rate than the ER negative patients. This slide summarizes NCCN recommendations, and as you see, there are mainly anthracycline-based therapies, or TCH or TCHP, and in the pre-trastuzumab era, HER2-positive breast cancers benefited from anthracyclines, perhaps particularly benefited. But given some of the longer-term toxicities we're seeing, including drops in ejection fraction, leukemia risk, and we're slowly moving away from anthracycline-based therapy in the era of the availability of HER2-targeted therapies. And we saw some data at ASCO that this year that supported a non-anthracycline regimens in this regard. And with that, I'll turn it over to Mayra to take us through some of the factors that we have to deal with in terms of patient education and treatment compliance with this regimen.
Thank you. Well, evidence-based delivery of patient and caregiver pre-chemotherapy education has shown that it reduces anxiety, improves understanding of the treatment schedule, improves compliance, and reduces potential adverse events. TCHP, as we know, is a complex and effective treatment for locally advanced HER2-positive breast cancers. And preparing the patients for prevention of adverse events through education and supportive measures leads to avoidance of dose delays, dose reductions, and possible discontinuation. Now, when I'm doing any pre-chemotherapy teaching, I look at 3 things that are of importance to me, and that is the black box warning, the serious adverse events, grade 3 and 4, and the most common adverse events, obviously. So we know that the black box warnings for this particular regimen are a left ventricular ejection fraction dysfunction, and it can be subclinical and it can be clinical. So it's very important to assess at baseline and every 12 weeks. And to notice if there is a decrease of 10% or more over the baseline, or a left ventricular ejection fraction less than 50, you want to hold the Perjeta and Herceptin for 3 weeks. And you resume it once the left ventricular ejection fraction has returned to baseline or equal to 50 or greater. Embryo-fetal toxicity, you know that we have now, the group of patients that we have are most of the time very young and of reproductive status. So you want to educate, and I'm very emphatic with this, and you will see this over and over again with most of our treatments. So I will try not to repeat it, but you must address this during the pre-starting treatment time because I have seen this fail, with the person not getting the appropriate teaching or emphasis, and it is a very sad situation. So they also must use the two forms of barrier contraception for at least 7 months after, or for 7 months after the completion of therapy. Hypersensitivity reactions is another one, and you want to observe closely for this, and you want to prepare them. Treatments such as docetaxel, they require pre-medication, and I'm happy to say that we hardly ever see any in our setting. And again, I mentioned diarrhea, and we must be proactive. This is a very dangerous side effect because a lot of times people, or especially women, tend to have constipation and they don't see it as an issue. And they don't start antidiarrheal therapies as we tell them on a timely basis. And this could lead to very serious adverse events in some cases. So again, education and supportive care with IV fluids or checking their electrolytes on a regular basis is very important. And again, the hematological toxicities, we've done pretty good with the growth factors and attending to them on a timely basis. Neuropathy, as you know, any treatment that has a taxane, or not necessarily even a taxane, but a tubular type of effect on the cells, will have neuropathy. And you want to assess that at the baseline. We do have a lot of patients that have diabetes and they come with it already. So, knowing where you stand is very important, and also treating it as soon as you get recognition that this is happening. You can do this through medications, and you can also do it with adjunct therapies like acupuncture.
Next, we'll turn it over to Dr. Rueda-Lara.
Thank you, Jennifer. So breast cancer diagnosis can be traumatic for patients and can trigger a variety of emotions that are normal. And I'm gonna go through the next slides over different phases, psychological phases that patients go through. Something that is important about this particular patient is that she has a history of anxiety, and that was prior to her cancer diagnosis. So you can imagine that her symptoms are going to exacerbate and is going to require an intervention. She's probably taking medications for anxiety and depression that, given this new situation, the medications need to be adjusted, or maybe we need to add other medications that are going to help her go through the treatment. Next slides, please. So patients frequently experience anxiety when they realize that a physician is recommending or conducting a medical evaluation to investigate the possibility of a malignancy. If the oncologist delivers a cancer diagnosis, this existential threat requires the patient to use a range of adaptive defenses to maintain psychological equilibrium. The diagnosis creates a period of expected crisis and understandable emotional upheaval. The initial phase is characterized by disbelief and denial. And something that is extremely important, and there's data that shows this, that the way that the news are delivered could be traumatic for patients. And patients share with me like different ways how they learn when they have cancer, like they were driving and they were contacted, and they would say like, oh, this is so-and-so, by the way, you have breast cancer, or different cancers. So I have tons of stories that patients share, and then they will never forget how they learned about their diagnosis. So
Maria, I'm sorry to interrupt you, but I'm so taken by that story. So can you give us some advice as to, from the perspective of the other members of the healthcare team, how do you think this news is best delivered? I mean, it's never an easy conversation.
I think they're best delivered if you can set up an appointment in person. But even now with COVID, we do telemedicine. When the patient has the time to sit down and has that space, but not when in the middle when they're driving or they're like picking up kids from school or they're at home doing homework with their children. It's just to have the time to meet with them and explain to them what the diagnosis is, if there is a plan. And sometimes, unfortunately, the news are delivered by non-oncologists, and they usually patients hear the word that, oh, you have like 2 months to live, or this already, and that patients get fixated on that number. So I think setting up an appointment and meeting with them and then letting them, being okay with silence while they process the information. Sometimes we have a tendency to want them, we have to continue talking. So silence is uncomfortable for everyone, but it's okay, like few seconds of silence while they process the information. I think that would help. So after the second phase of response to the diagnosis is characterized by dysphoria and despair as the reality of the diagnosis is acknowledged. The patient may experience depressed mood, anorexia, insomnia, and impaired concentration. And then they're so overwhelmed that they cannot function. But that period can last about 1 to 2 weeks. But the third phase represents a more enduring adaptation to illness, extending from weeks to months, during which the patient adjusts to the diagnosis and treatment and discovers renewed capacity for optimism and returns to previous routines and strategies of coping that are effective to minimize the stress. And the quality of adaptation depends on the patient's prior level of adjustment and emotional maturation. And in this case, this patient has a history of anxiety, so she's already predisposed, maybe having difficulties coping with a cancer diagnosis. Next slide, please. So there are different psychological interventions to reduce distress, and psychotherapy have demonstrated benefit, including like psychoeducational, interpersonal psychotherapy, progressive cognitive behavioral therapy, existential or meaning-centered psychotherapy. It is very important also to talk to patients about the sexuality side effects of cancer in treatment, to determine what type of social support they have, and also to connect them with survivorship programs at cancer centers. There are different medications that we use to treat anxiety and depression, especially when they go through the initial phase of diagnosis. We use medications that are relieve anxiety, like benzodiazepines that are short-acting. Also, some benzodiazepines are used when patients are receiving chemotherapy to decrease side effects like nausea. We also use antidepressants that are also indicated for anxiety, like serotonin reuptake inhibitors or serotonin norepinephrine reuptake inhibitors that can treat depression and anxiety in the long term. There are antidepressants, for instance, like mirtazapine, that are used in cancer patients when they have low appetite, they have insomnia, and they have nausea. Other medications that we use off-label are antipsychotics, for example, like olanzapine, which is also an HC3 antagonist that works similarly as an anti-nausea agent, like ondansetron. And many of the medications that are used for nausea are antipsychotic, like phenothiazines, like chlorpromazine, chlorperazine, that we could also use.
So the patient and her team decided on neoadjuvant chemotherapy. The patient completed 6 cycles of neoadjuvant TCHP with docetaxel, carboplatin, trastuzumab, and pertuzumab, with a partial response on examination. She was offered a lumpectomy and sentinel lymph node biopsy. And on final surgical pathology, she has 5 millimeters of residual disease and 2 negative sentinel lymph nodes. So the questions here: what would you consider for her post-neoadjuvant systemic treatment? What would you recommend regarding her radiation therapy options? And what recommendations from surgery for physical therapy post-op, especially lymphedema management and prevention?
So let's tackle the first question, which is the systemic therapy decision post-operatively. And many of us may already be familiar with this trial. This was a really important study that changed practice very quickly and led to approval of TDM1 in the post-neoadjuvant setting, the Catherine trial. So as a reminder, this was an open label study of about 1,500 patients with HER2 positive early stage breast cancer who were treated with neoadjuvant chemo that included a taxane and trastuzumab followed by surgery. Patients could have received an anthracycline and an alkylating agent, and 18% also received pertuzumab, as our patient in our case did. All patients had residual disease in the breast or axillary lymph nodes. Approximately 22% of patients had residual disease less than 1 centimeter. Remember, our patient had 5 millimeters of involvement. 22% had residual disease less than 1 centimeter and negative axillary nodes. Within 12 weeks of surgery, patients were randomly assigned to TDM1 at the dose that we're used to giving in the metastatic setting, shown here, or trastuzumab for 14 planned cycles. And the primary endpoint was invasive disease-free survival, defined as disease recurrence or death without recurrence. Stratification factors are shown on the bottom of the slide. So the primary endpoint was soundly met, with invasive disease-free survival events shown in the table to the right, observed in 22.2% of the trastuzumab arm versus 12.2% in the TDM1 arm. And you see the curve to the left showing the 3-year invasive disease-free survival rates, which were 77% and 88.3%, yielding a hazard ratio of 0.5 and an absolute difference of about 11%. So these were really impressive data. One area where we still have work to do is in terms of CNS recurrences. And although there was no difference in recurrences, numerically, they were higher in the TDM1 arm. And this is really something that we've seen in the adjuvant studies as well of trastuzumab, where you have a really effective therapy in reducing systemic recurrences, and then you have CNS relapses. So it's the concept of competing risks as opposed to any inherent increase in TDM1 in terms of causing brain metastases. But we certainly still have a lot of work to do in this area to prevent CNS relapses, because even with our best therapy, TDM1 here, we were not able to impact that endpoint. And again, just linking it back to our case, it's important to recognize, not shown here, is that all pre-specified subgroups benefited from TDM1, including patients with operable and inoperable cancers at presentation, the ER negative and the HR or ER positive patients, the patients that were post-neoadjuvant node positive as well as node negative. And again, linking it back to our case, even those patients with very small amounts of residual disease and negative nodes did get a benefit. The hazard ratio for those patients was 0.6. And so this again led to rapid adoption of this regimen in this high-risk patient population. So as we turn to a discussion about toxicity, and we have Mayra go through that information, I'll just give you some of the information in terms of grade 3 adverse events. And we know that patients in the metastatic setting who are treated with the therapy often don't tolerate that treatment as well in the adjuvant setting. And in the case of the Catherine trial, there were grade 3 or more adverse events in 15.4% in the trastuzumab arm and 25.7% in the TDM1 arm. And those events led to treatment discontinuations in 2.1 and 18% respectively. So with that information, I'll ask Mayra to take us through some of the toxicities that we should be aware of with regards to TDM1.
TDM1 side effects included hepatotoxicity, and again, knowing your baseline and monitoring prior to each treatment, the serum transaminase and bilirubin is of most importance. You also must reduce the dose. If it does not return to baseline, you must discontinue. It's recommended to discontinue. Cardiac toxicity, this is a trastuzumab-based therapy, and a MAGA scan or echocardiogram every 3 months to monitor the left ventricular ejection fraction is necessary, and withhold the treatment for any clinically significant decrease, and do not restart until it's back to the baseline. Embryo-fetal toxicity, most important to make sure that you do pre-treatment education, and strongly recommend 2 forms of barrier contraception during the treatment and for 7 months thereafter. And of course, no lactation. Pulmonary interstitial lung disease. The symptoms are dyspnea, cough, fatigue, pulmonary infiltrates on film. And obviously in this day and age when we have the flu and we have COVID-19, these symptoms can overlap. And the key point here is not to, is to listen to the patient when they do complain of these symptoms and act promptly. Permanently discontinue TDM1 in patients that are diagnosed with interstitial lung disease. Hypersensitivity, you want to monitor closely and treat as per your institution protocol. Hemorrhage was seen in this clinical trial in 0.4% of the study population, and they saw intracranial hemorrhage. Thrombocytopenia, you want to monitor closely with CBCs and platelets each cycle or sooner, and do not administer the platelets at less than 100,000. And grade 3 toxicities in general included anemia, hypokalemia, peripheral neuropathy, and fatigue. These are the most common side effects in this study, and that was fatigue, nausea, increased transaminases, musculoskeletal pain, peripheral neuropathy, and in 2% of the population, they had grade 3 toxicities, which included anemia, hypokalemia, peripheral neuropathy, and fatigue. All of them are manageable.
So for perspective, going back to the original description of our patient's extent of disease, she had breast primary tumor, and she also had a lymph node that was positive, and they had a great response to neoadjuvant therapy, and then had a residual 5mm mass in the breast and negative sentinel nodes. So when we're considering the radiation fields after breast conserving surgery, the standard of care after lumpectomy is really whole breast radiation therapy. Our standard fields during what we consider tangents, and that basically involves a field that covers the entirety of the breast. And as you can see from this image, also part of the level 1 and 2 axilla, kind of by definition, is included as we design our treatment fields. Now, when we think of the role of nodal radiation, it's really evolving in different settings and can vary when we are considering both the initial response to chemotherapy, the original extent of disease, and then also our perceived risk for future local regional recurrence. So the extent of nodal radiation after neoadjuvant therapy is very much a moving target, and even de-intensifying our fields based on response is under active investigation. So this is a great kind of retrospective review by Dr. Mack and Harris at Dana-Farber. And essentially, they looked at the patient's initial clinical status, both in the lymph nodes and also the primary tumor size, and then their pathological response after neoadjuvant therapy. And you can see the differences in terms of 10-year risk of a local regional recurrence. So when we look at the lowest risk patients, so those who had lymph node negative at presentation and also had tumors less than 5 centimeters, if they ended up having positive lymph nodes after chemotherapy, the risk of recurrence was somewhere on the order of around 11%. The highest risk patients are obviously those who had positive lymph nodes up front and large tumor size, who continued to have positive disease even after neoadjuvant chemotherapy. But we see that as we look at different combinations of patients, essentially those who have positive lymph nodes after neoadjuvant chemo are the highest risk, but it's not an insignificant risk in terms of local regional disease in patients who are even able to attain a pathologic complete response in the lymph nodes. So if we look at the next slide, kind of given these patterns of recurrence, that's why actively under investigation is whether we can de-intensify our radiation fields in the context of neoadjuvant therapy. So when we look at the trial schema for the NSABP-B51 study, here we're looking at patients who have clinically T1 to T3 disease. They have biopsy-proven lymph node positive involvement, just like our patients. And they have standard chemotherapy, including HER2-guided therapy, as would be relevant in the case of our patient. So all of these patients ultimately will have a pathologic complete response. And the trial basically looks at a combination of patients and stratifies for the extent of surgery. So for those who have breast conservation, they're stratified to either have whole breast radiation therapy versus with or without the lymph node treatment. And then for those patients who are able to have mastectomies, again, we're looking at treating the chest wall or the chest wall alone or with a lymph node field. This is a similar question that's being looked at in the Alliance trial, which I've shown the schema on the next slide as well. So basically, here, a randomized trial comparing axillary lymph node dissection with axillary radiation in patients who similarly have T1 to T3 disease and lymph node involvement, who then have a great response after neoadjuvant chemotherapy. So here we can see, so for patients who ultimately have a positive lymph node and then are randomized, arm one, they'll either have an axillary lymph node dissection and nodal radiation, which is a similar kind of treatment paradigm to patients in the MA20 trial, versus if they have positive lymph nodes on their final pathology and no axillary lymph node dissection, some of those patients are also treated with nodal radiation versus without, depending on the extent of a dissection. So it's kind of a companion trial, again, looking at de-intensification of the radiation fields, dependent on both the response to chemotherapy and extent of axillary surgery. So, now when we're thinking about kind of axillary management, we can't have this discussion without addressing one of the most common side effects that has a known impact on our patients, so lymphedema. So, this is a study that kind of summarized axillary management in patients who were enrolled on a prospective study for a lymphedema screening trial at Mass General Hospital. The patients were divided into different subgroups based on their extent of lymph node surgery and then whether or not they received radiation. And all of these patients prospectively had perimetry measurements of arm circumference before beginning their surgery and their subsequent radiation. And the study basically concludes that regional nodal radiation adds a significant lymphedema risk, but the main factor was actually extent of surgery, which is a large reason why for these patients, especially when they have a robust response to systemic therapy, there is this push to de-intensify surgery and not automatically commit them to an axillary lymph node dissection. So on the next slide, I have some figures from this review that basically shows kind of the cumulative incidence of breast cancer-related lymphedema over time. And a key thing is, one, the curves never really plateau. So this is a risk that we counsel our patient persists for the duration of their long-term survivorship. And the curves that are lower in terms of less breast cancer-related lymphedema are patients who have either a sentinel lymph node biopsy or sentinel lymph node biopsy followed by regional nodal radiation. So those patients with a higher incidence of lymphedema are those who either have an axillary lymph node dissection or the combination of axillary lymph node dissection plus regional nodal radiation. This is another figure from a similar review that also kind of looked at the hazard rate of lymphedema in different periods after surgery. And again, we see that the peak incidence is really at a year to almost a year and a half or almost 3 years out from their definitive surgery. And the patients who do the worst are those who have the combination of axillary lymph node surgery followed by regional nodal radiation. And as we de-intensify axillary management, we're really able to decrease the long-term risk of lymphedema. So again, especially in patients like this one, where even though she had biopsy-proven lymph node involvement, the fact that she was able to have a robust response to chemotherapy, it was absolutely appropriate to de-intensify her surgery to sentinel lymph node biopsy. And then the question as to whether or not she requires radiation therapy or not is under investigation, but the standard of care would still be to offer her axillary lymph node radiation, just given the initial pathologic involvement of the lymph nodes. Next slide, please. So, Obviously this patient, given she had a sentinel lymph node biopsy and then we'll have regional nodal radiation, she's at that intermediate to slightly lower risk of having breast cancer related lymphedema. But again, just a nod to some of the prevention strategies. And I'd love to hear if Mayra has any additional thoughts. But awareness is key. That's why, a lot of institutions, ours included, is really promoting doing prospective measurements. A lot of women already have kind of baseline arm asymmetry. So it's very important to kind of document their measurements before they've actually had their definitive treatment. Risk factors that are known include things like an elevated BMI, and our patient had this as a risk factor, but exercise is actually very protective, and there's research to show that increased fitness level and ongoing exercise programs are able to decrease the risk of lymphedema. Once a patient has the diagnosis, they can be referred to a dedicated lymphedema specialist. And then there's different options, including decongestive therapies, manual lymphatic drainage, obviously skincare issues, wearing a compression sleeve, and then other kind of preventative measurements. So things that have kind of made it into our dogma and our routine counseling of patients. So, things such as avoiding blood pressure measurements on the affected arm, avoiding blood draws, wearing compression garments. The data are actually kind of mixed in terms of their actual efficacy in preventing or improving lymphedema. But I'm curious what my colleagues say. I think most of us probably just err on the side of extra caution, since obviously once lymphedema occurs, it's pretty devastating from a quality of life standpoint. Though I think whether any of these behaviors actually cause lymphedema is totally it's mostly speculative, I think, at best.
So I'm just going to mention that the worst lymphedema in 14 years doing breast only that I see, or that I have seen, is the ones where there is involved lymph nodes and the patient is not responding and the lymph nodes were not removed. Or, that is really bad and usually devastating and usually not reversible. Once you go through all the steps, I think that, to me, the most important thing is eliminating the disease. Most of the lymphedema, unless it gets to a grade 3, and the idea is to prevent it from getting to a grade 3, because then it's reversible. You can help the patient, but other than that, it's very difficult.
Correct. And there are some new techniques surgically for lymph node transfer as well, kind of new and novel, but I have seen some drastic responses to patients who have maximized all the local physical therapy options too. Next, we'll continue on with our case. So 4 years later, the patient notes new onset of daily headaches and some right eye blurring. She undergoes a brain MRI and is found to have 3 brain lesions with some surrounding edema. Systemic imaging reveals 2 liver lesions and 5 bone lesions throughout the axial skeleton. So we have liver and bone disease here. She undergoes a liver biopsy revealing metastatic breast cancer, rechecking that ER, PR, and HER2 status, which remains the same at ER negative, PR negative, and HER2 positive. So what are our radiation therapy options for the brain metastasis?
So there are several different prognostic indicators to basically risk stratify patients in terms of their overall prognosis, because that definitely factors into our treatment recommendation. I've put this scoring down because it's the most updated version for our breast cancer specific prognostic assessment score. And you see the key factors are the patient's initial performance status, their age, the number of brain mets is very important, the extent of their extracranial disease, and then also the subtype, with obviously certain biological subtypes doing more favorably. And we'll talk about some of the data even in HER2 positive patients. So essentially those with favorable biology, controlled systemic disease, and fewer brain mets tend to do better, as we'd expect. This is a nice flow chart that kind of summarizes what are our different options. So for patients who have greater than 4 metastases, it used to be taken as a given that they would always require whole brain radiation. However, there's growing evidence that especially in patients who have stable extracranial disease, in the era of better kind of surveillance with MRI and also stereotactic techniques from a radiation perspective, we're actually able to treat many more targets safely, thereby minimizing the amount of kind of scatter radiation dose to the brain, and are improving our ability to really improve patients' performance status, or maintain their performance status, I should say. So for patients who have fewer brain mets, 2 to 4 generally, our go-to is usually stereotactic radiation. Patients who may have one, let's say, very large metastasis, depending on its size, we do discuss resection, and that should always be considered. And then in the context of after surgery, we'll sometimes then do either a stereotactic boost to give additional local control, or patients can then go on systemic therapy, and we'll get into some of those options in terms of CNS penetration in a bit. So, just wanted to include a slide that kind of shows the difference in whole brain versus stereotactic. So for patients who, let's say, have actually more of a miliary disease pattern or multiple brain mets, where functionally, to be able to localize several small targets, we treat a large integral volume of brain. Whole brain radiation is still appropriate. That involves daily treatments for 2 to 3 weeks. There are techniques to minimize some of the cognitive deficits, and those include things like hippocampal sparing whole brain radiation, also prescribing medications like memantine during radiation to enable patients to kind of have improved cognitive ability. But when it's possible, I think stereotactic radiosurgery and equivalent forms, so CyberKnife, Gamma Knife, et cetera. So techniques that allow us to really precisely localize the target and treat in a more focused manner, allow us to really spare a lot of normal brain and thereby minimize the cognitive effects, because obviously these patients are also dealing with side effects such as fatigue, and then possibly also a burden of extracranial disease that we have to consider. So the goal is to really minimize the time that they're under treatment while also controlling the CNS disease.
Next, we move on to the psychiatric issues of brain metastasis.
So brain metastasis can cause psychiatric symptoms, and also depending on the location of the lesions. If patients have brain metastasis in the frontal lobe, they can present with a change in personality, irritability, mood lability, and also if different lesions are located in the temporal lobe and the dominant temporal lobe, patients can have difficulties with language and can present with aphasia. Also, the type of treatment that they're going to receive is going to have an impact on their psychiatric presentation. If patients are going to receive whole brain radiation, they're probably going to receive steroids to prevent, for the inflammation. That also is going to increase anxiety, insomnia, irritability. And some patients can develop some psychotic symptoms, as well as hallucinations. As Kristina mentioned, there are strategies like giving memantine to prevent cognitive deficits, but also if patients are psychotic, we could use certain medications like antipsychotics to treat like irritability, mood lability, benzodiazepines, and antidepressants like serotonin reuptake inhibitors. Patients sometimes they're started on prophylactic medications as anticonvulsants that can cause psychiatric side effects. So it's important to take that into consideration.
Let's continue our case. So the patient receives SRS, so the brain metastasis, and is started on THP. She does well for 18 months and has progression of disease in the brain with 2 new lesions. She also develops 3 new liver lesions. So here we can see the guidelines. I think Dr. Mahtani, you're going to touch on this.
So Jen, if you don't mind, let's just go back to the previous slide. I think we should, stop and comment a bit on the local therapy decisions here. So just to remind the audience, this patient had neoadjuvant TCHP, had residual disease with 5 millimeters of involvement, negative sentinel nodes, and received TDM1 in the adjuvant setting per the Catherine trial. Then she has 4 years off of therapy. And I would say this case, which is clearly engineered, is sort of a look into the future, I'd say, because recall that TDM1 was approved in this post-neoadjuvant setting just in 2019. And so we're talking about, 4 years later, what the landscape is going to look like. I think in my practice, I haven't had the opportunity yet to see a patient who recurs in this setting. The challenges are going to be significant, I would say, in that situation, because now I would, of course, in a patient who has brain metastases and systemic disease presenting with metastatic disease, who's seen pertuzumab, seen T-DM1, I would love to get a tucatinib-based regimen. We'll be talking about the HER2 data approved first line, but as a reminder, that's a therapy that's approved based on HER2 in April of 2020 in combination with capecitabine and trastuzumab in patients who have received one or more prior anti-HER2 based therapy in the metastatic setting. So presumably the decision here in the first line would be to re-challenge with T-DM1 or to re-challenge with a taxane, trastuzumab, and pertuzumab per Cleopatra, recognizing that our patient was not represented on the Cleopatra trial. And then again, just pointing out that the 18 months here that she got out of this first line regimen, I would say is probably not going to be the case, although let's see, this is from the Cleopatra data. And again, our patient seems to have more resistant disease. And then at that point, she develops progression and also presents with systemic disease. So now we're talking about second line therapy after THP. The next slide was just meant to be a reminder about the ASCO guidelines, in which case in the metastatic setting, had she, for example, just progressed in the brain with continued control on THP, the recommendations are then to continue the same systemic therapy and handle the local disease with local treatment. But that's not the case in our case. In our patient, she had THP in the first line setting and then progressed systemically as well as in the brain. And so that leads us to the second line discussion. And Jen, I'll turn it back to you. I believe the next slides go over the HER2 data.
Yeah, thank you. So the HER2 study was a study of 410 patients randomized in a 2-to-1 fashion to tucatinib, trastuzumab, and capecitabine versus placebo, trastuzumab, and capecitabine. As we know, up to half of patients with HER2-positive disease are going to develop brain metastasis. Tucatinib is an oral TKI and is highly selective for the kinase domain of HER2. And usually well tolerated. Patients had to have an ECOG status of 0 or 1 and have a baseline brain MRI. And what we'll see as part of this study is patients were allowed to be on this study with active brain metastasis that were treated but still progressing, untreated and progressing, and then patients with a stable brain metastasis, which was 40% of the patients. So quite a broad range of patients with brain metastasis on this trial, which is usually not always allowed. So here we see the primary analysis results in progression-free survival by the blind independent central review here. And you can see at 12 months, we have 33% PFS in the patients receiving tucatinib versus 12% in the placebo arm. Overall survival out at 2 years, 24 months, 45% in the treatment arm versus 27% in the placebo arm. And then more specifically, progression-free survival for patients in the brain metastasis arm, 25% PFS at 1 year, 12 months for the patients receiving tucatinib versus 0% in the patients who are on the placebo arm. And so here is that data kind of in larger form here. Is quite dramatic when this was presented. This was recently updated at ASCO 2020 as well. Still with the 0% versus 40% for the patients receiving tucatinib. Median CNS PFS was 9.9 months on the treatment arm versus 4.2 months on the placebo arm. For overall survival in patients with brain metastasis, which was also updated at ASCO 2020, the risk of death was reduced by 42% in patients with brain metastasis. At 1 year, 70.1% overall survival in the tucatinib arm versus 46.7% in the patients in the placebo arm. Tucatinib, capecitabine, and trastuzumab, I found in working on the HER2 trial was very well tolerated overall. We do see diarrhea occurring in 81% of patients, though, have to be aggressive in the prophylactic antidiarrheals and electrolyte management, watching the liver toxicity with LFT evaluation, and then, of course, embryo-fetal toxicity we always have to keep in mind. So as the case continues, 6 months later, the patient is noted to have progression in the liver with new metastasis in the bilateral lungs as well. She's symptomatic. She has abdominal pain and a persistent cough, but her brain disease is overall stable. So what options do we have radiation-wise? We'll talk about first, and then we'll talk about some systemic therapy options.
So I do want to add even just the positive to the HER2 CLIMB data is the fact that it gives us a systemic option for patients even who had progression in the CNS after initial whole brain therapy or stereotactic radiation. So, as a radiation oncologist, it's very exciting that this is an additional option in our toolkit for these patients, even with refractory or recurrent CNS disease. In the context of this case, where we're saying now that her CNS disease is stable and potentially there are 1 to up to 5 sites of oligometastatic progression, we have the Sabre Comet study here that was recently updated in JCO that basically shows that in these patients, there can be a survival benefit to actually offering stereotactic ablative radiation therapy to certain sites of oligometastatic disease. So this was a randomized trial, looked at over almost 100 patients. Several different disease sites were included, including breast cancer patients. All of these patients had to have had stable systemic disease for at least 6 months, and they could have 1 to 5 sites of oligometastatic progression. And in some, now we've 5-year survival data that shows there's an overall survival benefit of about 25%. And there was even a 22-month improvement in the median overall survival in these patients. So an exciting option to be able to maintain a person on their given systemic therapy regimen, especially if they're tolerating it well from a side effect perspective, especially if there are limited sites of disease progression that can be treated reasonably using this radiation technique. In terms of mechanism as to why, this is just a larger, visual of the survival curves that show the benefit to the Sabre technique of radiation in these patients. Hypothesis generating, could it be sort of abscopal effect where we're modulating some sort of immune response that's allowing for better disease control systemically in spite of only treating focal sites? But regardless, I think this is an exciting option for patients who have solitary sites of progression, be maintained on a systemic therapy regimen they may be tolerating well.
Excellent. And so next we have the Destiny Breast-01 studies. This is another option for patients approved in December of 2019. Trastuzumab deruxtecan. This was the Destiny Breast-01 study was a study first looking at dosing and then continue on in part 2 at the final dose of 5.4 milligrams per kilograms. With the primary endpoint of confirmed overall ORR by independent central review. This is for patients who are TDM1 resistant, refractory, or intolerant. And so looking at this group of patients, it was 100% female, everyone was HER2 positive, good ECOGs, mostly 0 and 1, ER positive and negative were present, and the presence of visceral disease was in 91.8% of patients. There were patients with brain metastasis, but it was a little bit different than the HER2 CLIMB study. They had to be treated and asymptomatic. The patient prior treatments, everyone had had trastuzumab and TDM1, and you see here 65% of patients had had pertuzumab as well. Here was the quite dramatic overall response rate. We see in this waterfall plot here, 60.9% confirmed ORR with 11 complete responses here of the 168 patients evaluated. Looking at the progression-free survival and the overall survival, progression-free survival, pretty dramatic, 16.4 months. And we're kind of recalling that in Cleopatra, the PFS for first-line metastatic breast cancer was 18.7 months. The overall survival was not yet reached. And here I'll have Dr. Mahtani touch on one of these areas of special interest, the concern about interstitial lung disease with this medication.
So thanks. I'll just start by saying, we're focusing on ILD here because this is the most worrisome side effect associated with this drug. What we haven't gone through are some of the more common side effects, including nausea and GI symptoms related to this medication. Although I have to say in my practice with pre-medication, I've been able to handle the nausea pretty well. The AE of special interest, interstitial lung disease, I'll just start by reminding everyone that this is a broad term for a group of diffuse parenchymal lung disorders. And it's marked by the presence of inflammation or scarring of the lung interstitium. It's characterized by 4 main manifestations: respiratory symptoms, chest radiograph abnormalities, changes in pulmonary function tests reflecting decreased lung volume, and a microscopic pattern of inflammation and fibrosis. It can be very non-specific: cough, fever, shortness of breath. Those are the three main symptoms of ILD. And here you see patients who received the dose of 5.4 milligrams per kilogram. You see that there was an incidence of ILD with 4 patients grade 5, meaning death. And that's quite unfortunate, of course, when we have a patient that's participating on a clinical trial and passes due to an adverse event. And on the bottom of the slide, you see some of the further information that we know among these 25 events in total, any grade, or 13.6%. And it's notable that the median time to onset was 193 days, but the range was very broad, 42 to 535 days. 13 of the 20 patients with grade 2 or greater ILD received corticosteroids, and I won't read line by line, but you see the outcomes. For the 4 fatal cases, the onset, again, was very wide, 63 to 148 days. 3 had received steroids, and death occurred 9 to 60 days after ILD diagnosis. So we still have a lot of work to do to try to identify what the risk factors for ILD. So far, we have some information that the higher dose, which was used in the dose finding study, is associated, as well as patients of Japanese origin, but we're still working out what other risk factors are associated with this worrisome side effect. The important point to make is that we have to be hypervigilant. We have to engage our pulmonary colleagues, and remember, the differential diagnosis can be broad and include infection. And of course, as we are all dealing with COVID now, think of COVID as well, because from a radiographic standpoint, there are, of course, overlapping findings. So here, this is the recommended guideline for the management of trastuzumab deruxtecan-induced interstitial lung disease. And again, I'll just remind you all that grade 1 is asymptomatic, found on imaging. So this brings up the discussion about how soon we should be imaging, because you're not going to find something if you're not looking for it. So this is, again, an evolving discussion, because in my practice, I'll tell you, when the drug was first available, I started to scan patients every 2 or 3 cycles, very much like what was done on the clinical trial, and I just haven't been seeing it. And of course, there is the whole issue of patients becoming overburdened by these multiple scans. So I think we need to do some further work here to identify what the appropriate screening guidelines should be. But for grade 1, you're supposed to monitor and closely follow up in 2 to 7 days from the onset of clinical symptoms, and pulse ox and consider follow-up imaging in 1 to 2 weeks. And the important point that I've boxed here to highlight is that even with grade 1, so remember, this is asymptomatic, found on imaging, you're supposed to consider starting steroids at a dose of 0.5 milligrams per kilogram per day of prednisone or the equivalent until improvement, followed by a gradual taper. And if worsening or diagnostic observations despite the initiation of steroids, then you follow grade 2. And again, I'm not going to read this to you word for word, but with grade 2, it's a higher dose of steroids, re-imaging, and considering increasing doses of steroids if there's no improvement, consider additional workup. Of course, this is where we should really be engaging with our pulmonary colleagues. And then, of course, for grade 3 to 4 hospitalization and higher doses of steroids, the warning or the recommendation is to stop at grade 2. With grade 1, you can reinitiate at the same dose or a lower dose, depending on how long it takes for recovery. Next slide, please.
Yeah, so just any closing thoughts?
Well, I guess I'll just end by saying that I think that this is remarkable progress we've made in HER2 positive disease. The fact that we're able to pull together a multidisciplinary panel and talk about radiation options, systemic options, the importance of supportive therapies, it's just a testament to the progress that we've made in treating what was once considered one of the most aggressive subtypes in breast cancer. Of course, we still have a lot of work to do, especially in patients with early stage breast cancer and decreasing the risk of CNS relapse.
Excellent. Very good. I would like to thank our entire panel today and Total Health Conferencing for having this panel, a conference for women by women. And thank you for your attendance and attention. Have a great day.